Now, as we continue discussing thrombocytopenia or low platelet count, we've seen that it can be caused by several different mechanisms. It can be drug-induced, such as with heparin, or it can be autoimmune. Well, one of the other causes of thrombocytopenia is from disseminated intravascular coagulopathy, or DIC. Normally, when a blood vessel is injured, there's multiple steps in the process of hemostasis and the formation of a blood clot at the site of the injury. Now, if you recall, fibrinogen is made and secreted from the liver. And when there's vascular injury, fibrinogen is converted to fibrin, which, along with platelets, is going to form that blood clot. And then after it's formed, the body starts to dissolve that clot down into pieces called fibrin degradation products, or FDPs. This is so the clot doesn't get bigger than it needs to be. This process is known as fibrinolysis. So there's a steady balance between the formation of new clots and fibrinolysis. But oftentimes, there's serious medical conditions like sepsis, trauma, OB complications, or an acute hemolytic transfusion reaction that releases a procoagulant, such as bacterial endotoxins, that tips that balance of hemostasis in favor of clot formation. And this results in massive systemic formation of both blood clots and bleeding, and this is what is known as disseminated intravascular coagulopathy. Now, another term for DIC is consumptive coagulopathy. This is because this systemic clotting is going to consume platelets and fibrinogen, and bleeding starts to occur in the absence of these clotting factors. Now, so this paradox occurring between thrombosis and bleeding can lead to multi-organ dysfunction from vascular thrombosis, hemorrhage, and hypoperfusion. Now, DIC carries around a 40 to 80% mortality rate. Now, as far as diagnostics for DIC, first you're going to see a decreased fibrinogen level, generally less than 1 gram per liter. You're going to see decreased platelets, or thrombocytopenia, less than 50,000. And you're going to see a prolonged PT and APTT, and you're going to see increased fibrin degradation products. Now, you're also going to see an increased D-dimer. Now, this is a marker for fibrin degradation products, but it's important to remember many other disorders can elevate D-dimer, so it's not specific to DIC. Now, some of the common signs of DIC are going to include petechiae, you're going to see ecchymosis, you're going to see blood oozing from around the wound sites or IV lines. You might also see blood from catheters, drains, or mucosal surfaces. Also, you're going to see renal and hepatic dysfunction and other signs of shock or multi-organ failure. Now, as far as treatment for DIC, the first priority is to treat the underlying cause. Either treat the sepsis, you need to stabilize the trauma, or deliver the baby, or you're going to stop the transfusion if there's an ABO incompatibility. Now, next, you're going to transfuse platelets, FFP, and or cryoprecipitate, which is essentially liquid fibrinogen. You might also transfuse PRBCs. Now, there's little evidence for giving an antithrombotic like heparin, so it's generally not supported. And then as far as supportive measures, they're going to ensure hemodynamic and ventilatory support and aggressive hydration. Now, to summarize, DIC results from complications of sepsis, trauma, OB, or an acute hemolytic transfusion reaction. In DIC, a systemic inflammatory process results in microclots, which consumes coagulation factors like fibrinogen and platelets and results in bleeding. Now, these patients will present with petechiae and bleeding, and their lab results are going to show decreased fibrinogen and platelet levels, as well as an elevated PT-APTT, elevated fibrin degradation products, and elevated D-dimer. And the priority for treatment is to fix the underlying cause and transfuse platelets, FFP, cryoprecipitate, and or PRBCs, as well as supportive measures like hemodynamic and ventilatory management. Now next, let's take a look at HELLP syndrome.